Soon, we enter the first session of this webinar event. I will leave the series of events to the moderator to guide the next webinar.
Thank you, Dr. Lukas and MC. I hope you all can hear me clearly. So now I will give a brief introduction about all the panelists that are joining us today. So I will share my screen about their brief name and profile. Can you see the screen now? Dr. Lukas, can you see the screen?
Yes,
Please
yes.
confirm. Okay.
Yes, clearly.
Thank you. We have 6 panelists from international and national today. The first is Dr. Ahmad Imron. He is the head of Department of Neurosurgery in Hasan Sadikin General Hospital, Pajajaran University, Bandung, Indonesia. And then the second one, we have Professor Lukas Rasulic. He is the head department for peripheral nerve surgery, Clinic for Neurosurgery Clinical Center of Serbia, Belgrade. And he is the chairman of Peripheral Nerve Committee from World Federation of Neurosurgical Societies. And then we have Professor Tjokorda Bagus Mahadewa. He is the chief of Neurospine Committee in the Indonesian Neurosurgical Society. He is the professor of neurosurgery in Neurosurgery Department, Sanglah General Hospital, Yudoyono University, Bali, Indonesia. And we have Dr. Alfred Sutrisno. He was the past 5th president of APCSS. Now he is the consultant of neurosurgery in Omni and Pantai Indah Kapuk Hospital, Jakarta, Indonesia. And then we have Dr. Sandeep Vaishya. He is the executive director in Fortis Memorial Research Institute from India. And he is the executive board member of World Spinal Column Society. And we have Dr. Ruli Hanafi Dahlan. He is the head of Division of Neurospine, Peripheral Nerve and Pain in Neurosurgery Department, Hasan Sadikin General Hospital, Pajajaran University, Bandung, Indonesia. He is also the executive board member of World Spinal Column Society. And for webinar today, we only have one speaker. She is Dr. Debora Garozzo. Dr. Debora Garozzo is a consultant neurosurgeon. She is from Italy. She is specializing in peripheral nerve surgery with over 20 years of international experience and training from Italy, Sweden, Germany, and China. Present, she is the vice chairperson in the Peripheral Nerve Committee in WFNS. She is the vice president in Emirates Societies of Neurological Surgeon, and she is actively practiced as a peripheral nerve surgeon in Mediclinic Parkview Hospital, Dubai. Her areas of excellence are the micro-reconstructive nerve surgery, especially brachial plexus injuries, both in adults and children that we will talk about today, and then the entrapment neuropathies in the upper and lower limbs, and benign and malignant peripheral nerve tumors. So I will very glad to give the opportunity to Dr. Debora Garozzo, but before that, I would like to say thank you to John Bennett, to Neurosurgical TV, because our webinar today will be aired in the Neurosurgical TV. Thank you so much. So, Dr. Debora Garozzo, the time is yours now, please.
Thank you so much, Dr. Sevline. So first of all, I would like to say a big thank you to my Indonesian friends. I'm actually very sorry that today I'm here doing this webinar, because this is something that we had already started to organize more than 1 year ago. And I would have supposed to be in Bandung in April last year. And then COVID happened and all our plans were disrupted. Anyway, I'm still very happy to meet you, at least virtually, and then we are crossing our fingers and hoping that next time I will be actually in Bandung personally, and I would be delighted to meet you again and cooperate with you all. So I'd like to say a big thank you to Dr. Sevline, that I had the pleasure to meet a few years ago, Dr. Ruli, Dr. Farid, and Dr. Lukas for providing me this opportunity. And then I would like to say also a big hello to my friend Lukas Rasulic, that is always by my side when I do these things. And also Sandeep Vaishya, that I didn't have the pleasure to meet for so long now, and it's time to catch up, at least virtually. So, hello everybody, and well, let's start with this webinar that is going to be something that is going to take you across a journey related to brachial plexus injuries. So I'll basically try to provide an overview of brachial plexus injuries, starting from basic concepts and then talking about clinical diagnosis, and about management, and I will eventually talk about the surgical approach and the repair strategies, at least based on my experience. So I do hope that you can all see my screen. Can you see my screen?
Perfectly.
Yes, Doctor.
Clearly, okay. Dr. Debora. Very clear.
Okay, perfect. Thanks so much. So let's start. So as I said, the first lecture is going to be about basic concepts and clinical diagnosis in traumatic brachial plexus injuries. But before we're actually starting to talk about the technical details, I would like to attract your attention on brachial plexus injuries in history. Probably not many of you know that the first description in brachial plexus injury is already found in Greek literature and dates back to Homer. So in the 8th book of the Iliad, the Greek poet describes the duel between Teucrus and Hector. Hector tosses a stone that hits Teucrus on the collarbone, and Homer describes that the warrior immediately perceived his upper limb to become numb and paralyzed, and eventually this caused him dropping his arch on the ground. It's interesting to note that at that time, the ancient Greeks didn't know the difference between the tendons and the nerves. And it was only Herophilos of Chalcedon that was the first one to distinguish the nerve structures from the tendons. But we have to wait for a long time before we actually get the first anatomical description of the brachial plexus. And since I relocated in the Middle East, I think that it's important to mention that the first surgical repair of a nerve was actually attempted in Baghdad by the Persian physician Abu Bakr al-Razi. And then, you know, we don't have many mentions of brachial plexus injuries and nerve repair. And actually, they have been completely neglected in medical history till the early 19th century, when the French clinician Flaubert described root avulsions that he found in autopsy of 2 men that died after they had been submitted to a very forceful reposition of severe shoulder dislocation. And let me have a moment of Italian pride, because the first one to recognize the connection of motorcycle accident as important causative mechanism of brachial plexus injuries was an Italian, the Italian orthopedic surgeon Guglielmo Bonola in 1936. So let's start to talk about brachial plexus injuries from the technical point of view. And the first thing that we have to mention is that these are traumatic injuries basically related to traction. So whenever you have a forceful widening of the head-shoulder angle and a forceful widening of the arm-trunk angle, there might be a disruption, there might be a damage on the brachial plexus. So this picture here encompasses a wide spectrum of situations that might be associated with this kind of causative mechanism. But we know very well that the main cause are actually motorcycle accidents. Presently, the medical literature estimates the epidemiology of brachial plexus injuries as equal to 1% of trauma injuries. But we have to say that the spread into wheeler motorization in Southeast Asia has probably remarkably increased the incidence of this lesion that are apparently underestimated in the literature right now. What is important to emphasize is that besides their real epidemiology, brachial plexus injuries certainly have a very remarkable social impact. We have to consider that 95% of our patients are young males between 15 and 35 years. You can imagine the burden that it can be also, especially in communities already facing economical challenges. If you also have a member of the family that is invalid and unable to work and become a breadwinner. So brachial plexus injuries are important to be recognized and treated. Now, whoever knows the natural history of these injuries knows that you might actually have possibilities of spontaneous recovery, roughly about 30% of cases. But 70% of these patients do not present any potential for spontaneous recovery, and their only hope to have some functional restoration in the denervated limb is related to surgery. Now, what are the main key points that we have to emphasize when we talk about brachial plexus injuries and their management? The first thing is that obviously we have to identify and estimate the type of damage that was sustained by the plexus in order to perform a selection of the patients that present the possibility to spontaneously recover and those that might be given indication for surgery. And once you have advocated surgery, we have to understand when we are going to do surgery and then what kind of repair strategy we're going to apply. Now, the first thing that we have to consider is that evaluating a brachial plexus injury is different if it happens after, straight away after the causative mechanism, after the traumatic event, or later on. So clinical evaluation of brachial plexus injuries after the injury is actually kind of rather difficult. Most of the times patients are multi-trauma victims, they might be comatose, therefore they might not be able to attract themselves the attention on the physician on the deficit that they have sustained. And they might present also life-threatening injuries that captivate the attention of the treating physicians. So for all these reasons, neurological evaluation results extremely difficult, and this is the reason why brachial plexus injuries, especially in their partial clinical manifestations, may very often go unrecognized. So I'm trying here to give you some clues to keep in mind in order to diagnose brachial plexus injuries when you see a multi-trauma victim. Now, the first thing that we have to consider is that brachial plexus injuries might be associated with vascular injuries in about 15–20% of cases. So if you have a multi-trauma victim, always check for signs of vascular injuries, such as abnormalities of the distal pulsation at the wrist, possibilities of the occurrence of hemorrhage and ischemia in the upper limb that are usually related also to an overall picture of hypovolemic shock. Now, if you have such an occurrence, if you have a patient that sustained a vascular injury and a brachial plexus, these patients are usually urgently studied with an arteriography and given indication for vascular repair. The possibility that a vascular surgeon and a brachial plexus surgeon are working together on a surgical procedure on an emergency basis is very unlikely. Unfortunately, surgeons that are trained in brachial plexus are quite a few. So most of the times what happens is that the vascular surgeon will proceed to surgical intervention to take care of the vascular damage, and then the patient will be referred to the brachial plexus surgeon later on. Now, when you open a brachial plexus injury that was already submitted to surgery by a vascular surgeon, very often you are going to see that there might be a superimposed damage on the brachial plexus consequent to the first surgery. Vascular surgeons usually have to clamp in a hurry the ruptures of clavien artery, and in doing so, they may actually cause a damage also on the structures of the brachial plexus. This has to be accepted because, of course, the first procedure was to save the life of the patient, but it causes an additional burden on the damage sustained by the plexus. Now, besides vascular injuries, something that we frequently see in patients with brachial plexus injuries are bone injuries of the shoulder girdle, the cervical spine, the shoulder girdle, and the upper limb. So all the kinds of fractures may be possibly associated, but there are a few I would like to attract your attention on. So, a patient is a multi-trauma victim and that presents several fractures of the transverse processes or lamina of the cervical spine is likely to present brachial plexus injuries with avulsion of the roots. And another fracture, which is very frequently associated with brachial plexus injuries, is a fracture of the collarbone. We also have to consider that about 1% of brachial plexus injuries may result from compression on the brachial plexus consequent to displacement of the bony fragments of a comminuted clavicular fracture. And in these cases, it's important that this condition is recognized because immediate realignment of the comminuted clavicular fracture may actually be beneficial for the recovery of the brachial plexus. Now, another thing that is very important to pay attention to is the presence of an Horner sign that can be defined as an eyelid ptosis and meiotic pupil homolateral to the brachial plexus injuries, and the contralateral pupil is mydriatric. Horner sign usually appears immediately, but sometimes it can be delayed and be evident even after 24-48 hours from brachial plexus injury. It's sometimes not very easy to be recognized, especially in people that present dark eyes. And it also poses a question related to differential diagnosis with anisocoria due to head injuries. Besides the fact that I'm talking to neurosurgeons, and we know very well that if we have an Horner sign, of course, we have to evaluate the CT scan and try to assess the intracranial damage. Another things that can distinguish the Horner sign in brachial plexus injuries is that the mydriatric pupil is well reacting to light. If you see an elevation of a diaphragm on the chest ray, you always have to consider that the patient might have a brachial plexus injury because this finding, this radiological finding, is consistent with a palsy of the phrenic nerve. 2% of patients with brachial plexus injuries will present an incomplete Brown-Séquard syndrome that is resulting from an intramedullary hematoma consequent to avulsions of multiple roots. So far we talk about evaluation of brachial plexus injuries immediately after the trauma. And now we are going to talk about what you focus on when you see a patient in your office for consultation weeks or even months after the trauma. So again, the main thing that we're focused on is to try to evaluate the type of damage sustained by the brachial plexus and understand whether the evolution would be towards potential spontaneous recovery or the indication for surgery. So the main thing of our clinical assessment is to try to detect avulsions. So if this is a brachial plexus characterized by pre-ganglionic or post-ganglionic injuries. And obviously, we also have to frame, to classify the injury pattern based on the motor and sensory deficit. Why do we focus so much on trying to detect avulsions? Because if you have a brachial plexus injury with avulsive injury, without spontaneous recovery, and we will know from the very beginning that these patients have to be given indication for surgery. So the core of the diagnostic assessment, both clinically and instrumentally, is to detect pre-ganglionic abulgions injuries. So the differentiation between pre-ganglionic and post-ganglionic injuries. Keep in mind that the percentage of patients with brachial plexus injuries that present root avulsions is very high, 70%. And avulsions are more frequent at the level of C8 and T1 due to anatomical reasons. The upper roots of the brachial plexus present some collateral ligaments that reinforce that attachment to the spinal cord, whereas these ligaments are not present at the level of C8 and T1, and makes them more predisposed to the possibility of avulsions. 90% of root avulsions are associated with pseudomeningocele. So pseudomeningocele are like mushroom-like pockets filled with CSF, and they are caused by the fact that the trauma does not only cause a disruption, the avulsion of the roots, but also can cause a tear, a laceration of the dura surrounding the nerve root. Through such dural tear, there might be an echinoidal bulging that eventually becomes progressively filled by CSF, thus eventually forming the meningocele that you can see here at surgical exploration, and the appearance that they present on radiological investigations. So far we have talked about morphological signs of avulsions, but how do we actually detect avulsions? We can do that clinically, and we can also rely on imaging. So if you investigate a patient, you can already raise a suspect of root avulsions when you are going to encounter the different signs listed in this slide that I'm going to talk one by one in the next minutes. So we already mentioned Horner sign, and what I would like to say is that if you happen to have a patient that comes to your consultation weeks or months after the traumatic event, it might also happen that the Horner sign is not evident anymore. So you always have to ask the patient if he did present this anomaly of the pupils and the eyelids, or check on the official records to see if it was previously recorded. What causes Horner sign? So Horner sign is consequent to an injury of the stellate ganglion that is in close proximity to C8 and T1. Therefore, the occurrence of Horner sign indirectly is related to an injury of C8 and T1, namely an avulsion injury. And of course, it's a bad prognostic indicator. Pay attention to the denervation of the rhomboids. The rhomboid muscles are innervated by the dorsoscapular nerve that branches off very proximally. Therefore, a denervation of the rhomboid palsy is usually indirectly related to avulsions of C4 and C5. Sometimes if you have a patient that presents a bulky trapezius, it might not be so easy to detect the denervation of the rhomboids clinically, and it's better to rely on the EMG. So just ask your neurophysiologist specifically to check also the rhomboid muscles. Something that on the other side is pretty clinical evident, very clinically manifest, is a palsy of the serratus anterior and a winking scapula. Now, the serratus anterior, as we all might remember, is innervated by the long thoracic nerve, otherwise called the Bell's nerve. Now, the long thoracic nerve has origin from C5, C6, and C7. If one of these roots still is in continuity with the spinal cord, there is still residual function in the serratus anterior. So if you have a complete denervation of the serratus anterior and a winging scapula, this means that C5, C6, and C7 are avulsed. So again, this is a bad prognostic indicator. We already talked about the possibility of a phrenic nerve palsy, and here I need to emphasize that most of the patients do tolerate it quite well unless they have to make efforts. So you always have to check on the X-ray of the chest, which should be performed when the patient is breathing in order to detect the elevation of the hemidiaphragm. Concerning the lung tract pathways that we mentioned before, keep in mind that the deficit is reversible within a few months after the injury. But if you do have evidence that the patient sustained an incomplete Brown-Séquard syndrome, this is also a very bad prognostic indicator because it's related to multiple avulsions. The MRI scans that you see in these slides were the ones of a 25-year-old patient that presented a panavulsive injury of the brachial plexus. He had avulsions from C2 basically to T1, so a very extensive avulsions injury. And he presented this remarkable intramedullary hematoma. 3% of patients present an external meningocele, and this is really usually associated with devastating injuries of the brachial plexus. These are multiple avulsions with huge meningoceles. Another sign that you need to pay attention to when you are examining a patient with a brachial plexus injury is when they report about pain. Now, we know very well that pain is a very frequent complaint in patients with brachial plexus injuries. They sustain bone injuries, so they might have the pain related to the bone dislocations or fractures. Of course, there is the pain related to the rupture of the neural structures, but the pain related to avulsions is a very peculiar pain. Please take in consideration that almost all patients with avulsions complain about their afferentation pain. We don't know yet exactly the physiopathology of this peculiar pain, but the clinical manifestations are definitely very typical. The patients will report about pain that can be described like presenting two components. There is a persisting, a continuous pain described as a dull pain or a burning pain or something similar to the sensation that the patient's arm and hand are crushed in a vice. And then in addition to this, let's say, background pain, you have the sudden onset of paroxystic electric fits that mostly radiate on the hand of the and can be several even per hour. So here you see that most of the patients actually complain for more than 10 fits per day. But the truth is that in my clinical practice, I have seen patients that were really tortured by this pain. This pain makes them sleepless because it becomes more severe at nighttime and completely disrupts their quality of life. In the past, there were patients that even attempted suicide when they could not get a pain management therapy able to control their pain. And some patients also can present trophic ulcers in the denervated end. So, once we have raised a suspicion that there might be avulsions, and we have assessed the brachial plexus injury, of course, we have to try to classify the injury pattern, and we have to test the motor function in order to understand if this is a partial and what kind of partial injury it is, or if it's a total palsy. Please take in consideration that motor function is your most important reliable parameter. Sensory function might be often misleading because there is an overlapping of the dermatomes, and tinal signs can be misleading because if you have a partial avulsion with continuity of the sensory roots, then the tinal might be positive and therefore mislead you. Now, after we have completed our assessment, we can classify the brachial plexus injuries in different forms. We usually make a topographical classification between supraclavicular and infraclavicular injuries, the latter being less common than the former. And then we also distinguish the supraclavicular injuries in different injuries pattern. So 25% of brachial plexus injuries are related to an injury on C5 and C6, and eventually also the possibility that there might be the involvement of C7. These patients present a loss of shoulder movements, so no abduction, no extra rotation, and biceps. If there is also an involvement of C7, then the patient also will present the loss of the extensors. Upper brachial plexus palsy typically are characterized by a remarkable shoulder muscle atrophy that results in subluxation of the humeral head. And some patients can really present a very severe hypertrophy of the muscles, as you can see in these pictures here. Lower plexus palsies are definitely less frequent. They are actually kind of rather rare, probably estimated to be about 3% of overall brachial plexus injuries. 98% of these cases are systematically associated with avulsions of C8 and T1. The patient presents the preservation of the function of the upper part of the limb, but of course he has a distal palsy with complete loss of hand function. 50% of patients sustained a damage that actually impacted on the whole brachial plexus, and these patients usually present a flail arm. If we examine a patient with a total palsy, we are going to see all the signs, all the clinical manifestations that we saw before, the presence of the Horner sign, the subluxation of the humeral head, the winging scapula, all the signs that we mentioned before. So finally, 25% of brachial plexus injuries are related to a damage sustained at infraclavicular level. These are injuries which are frequently associated with vascular injuries, and the clinical presentation is definitely there's a wide spectrum of clinical manifestations that depends on the cords that are involved in the damage. So you might have a less severe clinical presentation, for instance, if there is only a damage on the posterior cord, or if the three cords have been involved. After you have diagnosed a patient with a brachial plexus injury, you need to give indication to wear a sling to support the flail arm in order to prevent that the weight of the denervated limb is stretching the structures of the shoulder joint, and therefore third are predisposed to degenerative changes. And these patients should be given indication for physiotherapy on daily basis. This is very important because we try to maintain the muscle trophism as much as we can with passive movements and also prevent the onset of stiffness of the joints. Pain management therapy, as I mentioned before, is very important, not only because we need to try to provide to the patient the best quality that we can, but also because if the patient is in severe pain, of course, the physiotherapy treatment is impaired. They cannot work with the physiotherapist, and therefore this exposes them to develop more severe degenerative changes. So far, we talk about the clinical management, and now we are going to talk about the instrumental workup. So electrodiagnostic tests should be performed at least after 3 weeks after the traumatic event. If they are done earlier, they are not able to differentiate between neuroapraxia and other form of more severe nerve damage. Consider that it could be possible to distinguish between pre-ganglionic and post-ganglionic injuries on EMG and nerve conduction study, but we also have to raise a concern. These investigations are highly depending on the expertise of the operator, and therefore I have to say, in my experience, they eventually proved less useful than we would like them to be. Neuroradiological investigations undoubtedly nowadays are the core of the diagnostic assessment. A lot of people still consider Mylo-CT, but I'm afraid I have to say that Mylo-CT role is definitely over. It should not be considered the first choice investigation anymore. It's an invasive technique. And also, we have to consider that the information provided by the first choice investigation, that is a three-dimensional MRI, is definitely much more complete. Imaging of brachial plexus injuries with three-dimensional MRI based on MRI, myelography, neurography, and DTI does not only provide information about the presence of root abulgions, but can also provide information about injuries along the course of the nerves. So at this point, we have been able to understand whether the patient that we examined as a damage that is potentially predisposed to spontaneous recovery, and therefore can be just given indication for conservative management with physiotherapy, or if the damage, like in the case of multiple avulsions, is irreversible, and in this case, the only hope to restore functional action in the denervated limb is related to an indication for surgery. When shall we give indication for surgery? What is the appropriate timing for this kind of surgery? If your clinical assessment raised the possibility that the patient presents avulsion of the roots, which have been confirmed by the diagnostic assessment, surgery has to be taken in consideration as soon as possible with the overall general clinical condition of the patients, because avulsions, as we already said before, cannot be associated with any possibility of spontaneous recovery. So the sooner, the better. But if your assessment, both clinically and radiologically, did not find out signs of avulsions, then you can initially adopt a wait-and-see approach for a few months. You monitor the patient clinically and by electrodiagnostic test. And at that point, that you don't see any signs of recovery, after 3-4 months, then you have to go for surgery. You have to advocate surgery. So that was my first talk, and I thank you for your attention so far.
Thank you so much, Dr. Debora. And I think now we have one question in the comment below. Probably you can see it too. Can you see it? Okay, so the question is from Dr. Justinus Robi. He asked about number one, how can we diagnose BPI from the unconscious patient if they suffer from cortical intracerebral hemorrhage that affects their motor function or some large midline shift lesions? And then the number two, how can we differentiate BPI from compartment syndrome in extremity fracture patients as they mimic the symptoms? And the third, when will be the perfect time to start surgery of BPI in simple or multi-trauma or unconscious patients? Please, Dr. Debora.
Okay, so first of all, related to the questions, I thought actually many of the replies to these questions were actually in my presentation. So a patient that is unconscious, as I said, first of all, you have to examine the scans of the CT, and then you have to see if the CT scan shows some injuries that can differentiate that the patient has an injury on the brachial plexus. If the patient is unconscious, you rely on the indirect signs, as I said. So first of all, you might suspect if there was a vascular injury. You might consider the presence of the fracture, and you have to consider that even in unconscious patient, when you perform a neurological evaluation, you are going to see if there is some response on one side. So if you see, for instance, that there is no response at all on one limb that also is ipsilateral with the Horner sign, where there is a clavicle fracture, if you see the X-ray of the chest that shows a phrenic palsy, I mean, these are all elements that can eventually lead you to suspect that there might be a brachial plexus injury. Then compartment syndrome is something that, in my opinion, is clearly completely, there's no possibility to not be able to distinguish a compartment syndrome from a brachial plexus injury is kind of rather pretty straightforward. And when it comes to timing for brachial plexus injury, well, of course, as I said, the timing, if you have avulsions, has to be as soon as possible. But you have to consider also the capability of the patient to undergo a procedure that is under general anesthesia and may last for several hours. So, of course, first you have to assess the general condition of the patient. You have to talk with your anesthesiologist, and then you have to decide when the patient is fit to go for the surgery. Brachial plexus injury are related to improving the function and therefore the quality of life of a patient. So, of course, they have to be treated secondarily to other injuries that might, or considering other situations that might represent an hazard for life for the patient.
Oh, thank you, Dr. Debora, for the explanation. I invite our panelists, probably Professor Lukas Rasulic, because as I know, he performed this brachial plexus surgery very in a large number. So do you have any comments about the third question, about the perfect time?
Good morning, everybody from Belgrade, from Serbia. I'm very happy that I'm invited to participate in this wonderful webinar. Congratulations to the organizers, and I fully agree with my dear friend Debora that Indonesia is a beautiful country, and we enjoy very much every time when we are in Indonesia. We have been several times, and I hope that we'll meet soon. Wonderful memories and excellent neurosurgical service, especially because of the real extensive interest to the peripheral neurosurgery, especially brachial plexus surgery. Now, this webinar today is one of the excellent examples how things should be organized for education through online platforms. And I just want to say that Debora presented a wonderful presentation, excellent presentation, basic and clinical aspects of the brachial plexus, which is enough for the, let's say, first understanding for the beginners. But my suggestion would be that in your departments for peripheral neurosurgery and brachial plexus surgery, all who would show the interest for brachial plexus and peripheral neurosurgery, start to work with the patient very intensively. Of course, nowadays with this unprecedented times, COVID-19 pandemic situation, it can be very difficult and problematic. But anyhow, this is a very important clinical activity with the patient. You have to examine the patient, to think about, to make a correlation between the results of diagnostic procedures with your correlation, with your clinical findings. And it will lead you in the future, when you become more and more experienced, almost to the right choice of your surgical strategy for what you will hear in the next presentation of Debora. Debora is a very experienced brachial plexus and peripheral neurosurgeon, so I'm sure that Debora and myself also and all other members of the AAFNS Committee for Peripheral Neurosurgery would accept everybody who would like to join us for some kind of fellowship, internship in these circumstances, in order to make this kind of education more important and more visible. And on the other hand, this webinar has another very important point, and this point is multidisciplinarity. As I understood in this webinar, they are not only neurosurgeons, but they are orthopedic surgeon, plastic surgeon, neurologist, radiologist, and all other people. This is very important for this multidisciplinary approach and treatment of this patient. If it is all under one roof, it's ideal, but if it's not, you have to have a very nice patient flow in order to make a collaboration with other specialties. So far, so good. I congratulate you once again. I do not take you more of your time. And I'm just very pleased that I have here one of the colleagues whose name is Lukas also. So I was a little bit confused that when somebody say Lukas, I don't know who to usually is also
Lukas.
Which Lukas is actually. So anyhow, my special regards to my dear colleague with the same name.
From now on, we will only call you Professor Rasulic, because we have two.
Oh, no, Lukas is fine. Lukas is fine. That's okay. Everybody call me Lukas.
Yes. Yes.
Dr.
Thank you,
Professor Lukas.
Rasulic.
Yes.
I will
Professor.
invite all the
I've seen.
And then
there are two more questions here on the chat. I wanted to, yeah. No.
Okay.
Plexus avulsions and
Yeah. Okay. Okay. Thank you, Dr. Lukas, for all the people, and Dr. Debora. Thank you for very nice presentation for you. Thank you very much. This is a question for the newborn.
Okay, so this webinar, in my opinion, was just based on adults. So I didn't completely mention obstetrical brachial plexus injuries. Okay, so first of all, we have to consider that avulsions in brachial plexus injuries in newborns are actually quite uncommon. You know, the mechanism, the causative mechanism is completely different. Of course, a delivery is a low kinetic energy event, and differently from a motorcycle accident. So the incidence of avulsions in newborns is actually very low. Mostly we find them just in total pulses, or if we talk about Gilbert-Tassen type 1, which is the C5-C6 or the C5-C6-C7, usually you may have avulsions only if the baby was born with a breech delivery. we follow different indications for the timing in newborns. So if you have a baby that presents a total palsy, and total palsy means that this baby presents a flail arm that might be associated with an Horner sign, or sometimes they don't have an Horner sign, but they have a flail arm. These patients for sure have to go for surgery. And usually we try to do surgery when the baby is 3 months old, because, we have to consider that the risks of general anesthesia in newborns are very high. So we have to find a compromise between trying to go for surgery as possible, but at the same time also protect the health of the baby. So if you have a baby with a flail arm, then you go for surgery when the baby is 3-4 months. If the baby has a partial injury, if he has a good hand, but he has an impairment of the shoulder and the elbow function, so like in C5, C6 or C5, C6, C7, even if there is an avulsion, you anyway wait and you go for surgery when the baby is like between 3 and 6. So you can, wait a little bit longer. I do.
Thank you, Doctora.
Okay.
Doctora, wait. I think the physiology of the babies is different from the adults. Like fractures, you see green stick fracture for the like bone. Also, I think maybe something at investigation, MRI, myography, maybe not go make very accurate to make avulsion. Maybe we think we avulsion and not avulsion when you're in a small baby.
So talking about obstetrical palsy actually would require a completely different webinar, because even if we're talking about brachial plexus injuries, the features and the issues related to the management of neonatal brachial plexus injuries are completely different. What I can tell you just, and you're welcome to touch base with me by email, and if you want, we can even make a Zoom and more specifically focus on this, is that assessment in children, in babies, is mainly the only babies that we give indication to be submitted to MRI, because of course in babies this requires sedation, general anesthesia, are babies with a flail arm. If you have a partial injury, if you have just a C5, C6 or C5, C6 or C7, the assessment is not done instrumentally, but it's done clinically, and it's based on the recovery of the biceps. Anyway, Dr. Omar, if you want to talk about that, as I said, I'm absolutely available to have a face-to-face discussion in a separate situation. The last remark I want to do about obstetrical brachial plexus palsies is that you are not supposed to give indication for EMG and nerve conduction studies in these babies. First of all, because the findings are very controversial. Babies present something which is called luxury renervation or aberrant renervation, and they always present some signs of renervation, even in the muscles which are completely not functioning. So the EMG is actually misleading. It's not on the EMG that you decide whether you are going to give indication in these babies for surgery or not. And also, again, you have to give sedation to the baby to do the EMG and nerve conduction study. So, of course, this makes, the situation even more complicated. And so it's the only thing, the only way to assess children, the babies, and give indication is to follow them from a clinical point of view. I do hope I was clear enough, but as I said, if you want, because I understand that you are particularly focused on this kind of injuries, we can, discuss about them later on. Email me, and we can talk about that. And
I'm sorry, Dr. Debora, do you mind if we share the question with the other panelists?
No, not at all.
Okay, I think I'd like to ask Dr. Sandeep. Vaishya is here with us now. Dr. Sandeep, how about your opinion about the second question about do you check all the muscles innervated by brachial plexus in the neurophysiology for the brachial plexus injury? Please, Dr. Sandeep.
Yeah, so as Debora mentioned that we check most of the muscles. Basically, our aim is to find out whether it's a pre-ganglionic or a post-ganglionic, and depending on the muscles, as she explained in her lecture, you can mark out which muscles are pre-ganglionic injury and which is post-ganglionic. So you need to start right from rhomboids to lower down. All the muscles which are absolutely normal, we usually don't check.
Okay, thank you, Dr. Sandeep. Dr. Debora, you want to add something for the question?
Well, as I said, EMG and nerve conduction studies in patients sometimes are not providing as much information as we would like to. I think, of course, we have to include the assessment of the paravertebral muscles. The trapezius is also important to be included, the serratus, and of course, all the muscles of the shoulder girdle and the upper limb. So it's a long investigation. It's very time consuming. It's very demanding. And this is why if you have a neurophysiologist that is not familiar with this kind of injuries, the EMG and nerve conduction study is probably going to be, I'm sorry to say that, 90% or probably even more absolutely useless.
Thank you, Dr. Debora. And I think for this session, we only have one last question from Julius. We will talk about the delay surgery could restore the muscle mass. Probably I would like to invite our panelists, Dr. Alfred Sutrisno. Is Dr. Alfred is here? Well, probably Dr. Debora, you can answer too. Give comment about the
Dr. Christian
surgery.
Okay, so I see here, I would ask you about the patient selection. When do we decide to operate or not to operate the brachial plexus injury? And then the second question, in the acute case of brachial plexus injury, we need to refer the patient to the higher medical hospital level. How to immobilize the nerve during the referral? Is there any specific instrument for the brachial plexus injury, such a collar neck in the cervical injury? Thank you. Okay, so when do we decide to operate or not to operate the brachial plexus injury? What do you exactly mean? Do you mean if there might be cases where I have considered that the patient is not a suitable candidate for surgery anyway? Okay, so I can tell you that in my practice, I think I have operated hundreds and hundreds of brachial plexus injuries, but there have been a few cases, probably a dozen, when I said, okay, the situation is really so bad that even the surgery is not going to be of any benefit. And the last of these cases is exactly a patient that I am presently following here in Dubai. So this guy had an accident in November. He had a multi-trauma, is 38 years old, is diabetic. He already was submitted to surgery, cardiac surgery. And he has more than, I think he has 3 cardiac bypass. So he was already in a rather, peculiar condition before the accident. Then he had a motorcycle accident. He sustained a very severe multi-trauma with kidney failure, remarkable thoracic cage injuries and everything. And he has a brachial plexus injury. The brachial plexus injury actually showed evulsive injuries from even the cervical plexus. He has a complete denervation of the ipsilateral trapezius. He has panavulsions, and he also had multiple ribs. mostly starting just at the proximal part, where the ribs are connected with the spine. And he developed an ossification also of all the ribs at that level. So basically, I have a guy that presents a very heavy past medical history, potentially not a good candidate for renervation because he's diabetic, and we know very well that diabetes definitely impairs the regeneration process with high risk for surgery, and basically no, as you are going to see during the second presentation, and basically no donors for the procedure. Is ipsilateral trapezius is completely denervated, so the spinal accessory doesn't work, and I cannot even use the intercostal nerves. So this is a patient where I decided that, in spite of the fact that the brachial plexus, of course, is an irreversible lesion, there is no possibility even to do a surgery because I don't have donors for the procedure. And you're probably going to understand my remarks better when I talk in the next presentation. And for the second part of your question, how to refer the patient to the higher medical hospital level. No, we just, yes, as I said, we just provide this link to support the flail arm, but there is not much that you can do. I mean, once the damage has occurred, it has occurred, we cannot do anything for it.
Thank you, Dr. Debora. And I think because of the time, and we have so much to talk about the surgical strategies, do you mind if we jump to the second session? So we can invite the panelists. Yes, because it's going to be more complicated, I think, and there will be more discussion with all the panelists about the surgical strategies. Okay, if it's fine with you, we can directly move to the second session, Dr. Debora.
Yeah. So again, can you see my screen?
Perfectly.
Okay. So, so now we resume talking about brachial plexus injuries related to the way we surgically treat them. And again, I'd like to briefly overview what happened from an historical point of view. Sir William Thornburn was the first surgeon to attempt a brachial plexus repair that happened in 1896 at the Royal Manchester Infirmary. After his surgical procedure, other surgeons were prompted to follow his example. But unfortunately, already a couple of decades later, surgeons were discouraged to attempt brachial plexus repair because of the poor outcome, and especially because there was an incredibly high rate of mortality related to this kind of procedures. So it seems that, again, we have some complete neglect of brachial plexus injuries till the Second World War. When there is a remarkable surge of brachial plexus injuries. And again, in UK, Sir Seddon and his team attempted brachial plexus repair. But again, this wave of enthusiasm faded shortly afterwards because the outcome was generally very poor. So we eventually reached 1966 when in Paris there is the 10th conference organized by the International Society of Orthopedic and Traumatology, and they reviewed the cases that submitted. So they came to the conclusion that surgical repair of brachial plexus injuries was almost impossible because it was related with a very poor outcome. and therefore it should be abandoned. And there was a general agreement that these patients should be just offered above elbow amputation and the use of prosthetics. So 1966 was basically the year where the therapeutic nihilism reached its climax. And we have to wait till about 10 years later, when Anno Millesi in Vienna and Algimantas Narakas in Lausanne in Switzerland resumed brachial plexus surgery. And they are undoubtedly the fathers, the pioneers of modern brachial plexus surgery. And we basically started following their example. So talking about brachial plexus surgery, what are we going to focus on this lecture? I will try to offer an overview of what I believe are the key points in these procedures. We're going to talk about general preparation for brachial plexus surgery. We're talking about how to perform a surgery, which should hinge on two stages. One phase, which is the exploration of the brachial plexus, and then the actual micro-reconstruction. So when it comes to general preparation, of course, these patients are going to be operated just in general anesthesia, and you have to remind your anesthetist that muscle blocks cannot be used because we need to stimulate the neural structures. So we always have to have handy intraoperative electric stimulation, and we always have to perform this surgery under magnification. So I use magnifying loops during the exploration stage, and then I resort to the operative microscope for the stage of the sutures. Talking about sutures, sutures should be performed with nylon 9-0 or 10-0 sometimes. And then I add some fibrin glue, and the sutures are always done under the microscope. Please consider when you use fibrin glue that not all the fibrin glues that you find are suitable for nerve sutures. So always check in the indication. So in brachial plexus surgery, basically, we decided the repair strategy based on the findings for pre-operative diagnostic assessment and what we found at surgical exploration. And surgical exploration should encompass exploration at the supraclavicular and the infraclavicular level. Nowadays, some surgeons advocate that we could even skip surgical exploration, but I absolutely do not agree with that. Surgical exploration, especially in total palsy, is still mandatory. Instrumental assessment is not 100% accurate. We still have false positive and false negatives. That can be misleading. And there is also another reason. 5% of supraclavicular injuries are associated with the distal rupture of the musculocutaneous or axillary nerve. So if you do not explore the infraclavicular plexus and you just concentrate your work on the supraclavicular area, then you probably have high risk of having your work jeopardized because there was an injury that was more distal that was not detected. Surgical findings at brachial plexus exploration encompass a very wide spectrum of surgical findings. We can have findings related to pre-ganglionic injuries. I have very often seen meningocele and even clearly the roots avulsed from the cord. It's obviously much more frequent and much easier to detect, to carefully assess the postganglionic injuries that might be related to rupture of the nerve immediately after the exit from the vertebral foramen, or there might be a distal rupture along the course of the primary trunks, the cords, and of course the terminal branches. And a form of a type of damage we seldom mention is the avulsion of the nerve from the muscle. This is rare, but it's also a kind of rather irreversible damage to treat. So when it comes to the actual repair strategy, of course, we know that we can rely on techniques like graft repair and neurotizations. So graft repair is obviously suitable only if the nerve still presents continuity with the spinal cord. We usually harvest the sural nerve, but if the injury already caused a functional loss in these nerves, also the medial cutaneous nerve of the arm, the radial sensory branch, and sometimes even the ulnar nerve can be used. So again, I need to emphasize these are nerves that you can use in total pulses when there is a clear functional loss of the nerves. So if you have avulsions of C8 and T1, then you're entitled, for instance, to use the ulnar nerve. Okay, but otherwise, of course, you're not going to use the ulnar nerve as a graft in a different condition. So the nerve graft is prepared. It's a cable graft that, of course, have to be as long as the gap that you want to repair. But we have to consider that nerve grafts for sure cannot be used in situations where we have avulsions, because in avulsions we have lost the continuity between the nerve and the spinal cord. So avulsions oblige us to resort to a different group of techniques, which are called neurotization techniques. So what does it mean, neurotization? So neurotization or nerve transfer is a surgical technique that implies that we take the proximal stump of a nerve that still presents continuity with the spinal cord, and then we will connect this stump with the distal stump of a ruptured nerve or an avulsed nerve. Obviously, the function of the donor nerve has to be considered less important than the function of the avulsed or ruptured nerve that we want to restore the function of. So we have different forms of neurotization. So we can distinguish an intraplexal neurotization, an extraplexual neurotization, and the so-called distal neurotizations. What we define as intraplexual neurotization is a technique where we use as donor nerve the proximal stump of a ruptured root, and we bridge that stump with a graft to the recipient nerve, whose function we want to restore. The donor nerve is a root whose rupture occurred after the exit from the foramen. And to give you a better example, for instance, imagine we have a case of a patient that sustained a total palsy with a C5 rupture, and then the remaining roots being avulsed. So what you can do is that you can take a C5 proximal stump and then connect it with a graft, for instance, to the anterior division of the upper trunk to restore the biceps. So this is a perfect example of intraplexual neurotization. Extraplexual neurotizations implies that the donor nerve is actually not part of the affected plexus. There are several that have been attempted in the past decades, and some of these we actually abandoned them. Like, for instance, the cervical plexus of the hypoglossal nerve, we found out that the outcome was very poor. So the four extraplexual donor nerves that you see here, the accessory nerve, the intercostal nerves, the phrenic nerve, and the contralateral C7, are the ones that are presently in current practice. So spinal accessory nerve is definitely an excellent nerve transfer. It's a very reliable procedure. It's usually applied to restore the function of the suprascapular nerve, the spinati muscles. So it can be performed via an anterior approach or a posterior approach. I'm not going into details of this, but it's usually a very good procedure, provides satisfactory results. The spinal accessory nerve has also been used with the interposition of a graft to restore the musculocutaneous nerve, but we have to say the outcome is definitely mostly poor, and personally I don't rely on this procedure anymore. Now, the phrenic nerve is extensively used, especially in Asian countries. It was introduced in China by Gu Yudong, and it's used also in other countries of Southeast Asia. It's used in India. It's used in Thailand. Some Western surgeons also have started to use it. Now, we might probably talk about that better later on, but there's no doubt about the fact that the phrenic nerve is a good donor. It provides very good results. But there is something that we have to consider. As I mentioned before, brachial plexus injuries are injuries that we surgically treat because we want to provide a better quality of life to patients, which implies that we should not use techniques that might result potentially dangerous for the overall well-being of the patient. Now, phrenic nerve as a donor is a very controversial nerve. First of all, you have to consider, and this is something that I would like to emphasize, especially for Dr. Amr, that it should never be used when performing surgery for neonatal brachial plexus injuries. Using the phrenic nerve in children younger than 36 months has actually resulted in tremendous consequences, tremendous complications. Children develop continuous infections, respiratory problems, and even thoracic cage deformities, okay? There have even been cases of children that died because of complications related to using the phrenic nerve, okay? So never to be used in children under 36 months. But also in adults, I think we should probably be very careful. We have to consider that we harvest the phrenic nerve in patients that are usually very young. I mentioned during my first lecture that normally patients have an age between 15 and 35 years old. So what happened on the respiratory function when the patient ages, when we know that after 55, 60 years, we already have a progressive impairment of the respiratory function, which is, related to aging. What are our patients going to do if they were submitted to a phrenic nerve harvest when they were young? So again, let's consider that we do not have any long-term studies, and this could be a potentially dangerous surgery. Intercostal nerves to be used as donors in this kind of procedures are definitely very safe. Unfortunately, sometimes you have to rule out their use. For instance, like in the case I mentioned before, multiple ribs fractures, or also if the patient sustained a Brown-Séquard syndrome, because in these cases, obviously, there was a damage on the medial cord that will affect also the thoracic spine, and therefore the potential for renervation of the intercostal nerves has been clearly damaged, clearly reduced. So we harvest the intercostal nerves usually from the 3rd to the 6th. The first and the second intercostal nerves cannot be used for neurotization to regain motor function because they are mainly sensory fibers. And if you try to harvest the intercostal nerves, which are lower than the 6 intercostal nerves, then they become too far away from the recipients, and therefore you need the interposition of a graft that compromises the possibility for favorable outcome. So usually we select the 3rd, 4th, 5th, and the 6th intercostal nerves. So for this kind of nerve transfer is to renervate the musculocutaneous nerve to restore the biceps. But there can be also other uses. I've used the musculocutaneous nerve also, for instance, in cases where I wanted to renervate the triceps, in patients where I could regain the biceps functions with, for instance, an intraplexural neurotization from C5 to the anterior contribution of the upper trunk, and to restore the long head of the triceps. You also get a good results on, you increase also the stability of the shoulder. So this is an example of intercostal nerve transfer to triceps. So how do I use the intercostal nerves? Personally, I harvest the 4 intercostal nerves, because what I do is that I use the 3rd intercostal nerve to renervate the long thoracic nerve. So at least I try to provide some renervation of the serratus anterior, reduce the winging scapula, and therefore provide more stability to the shoulder. And then I harvest the 4th, the 5th, and the 6th intercostal nerves, and I harvest both the motor and the sensory components of these nerves. So then I will go proximally, I will resect the lateral cord at the splitting into musculocutaneous and lateral root for the median nerve. I reroute the 2 nerves proximal to the intercostal nerves. And what I do is that I coapt the motor components of the intercostal nerves to the musculocutaneous to regain the biceps. And I coapt the sensory components of the intercostal nerves to the lateral root for the median nerve in order to restore sensitivity, protective sensitivity of the hand in the median territory. The 4th extraplexual donor I'm briefly going to talk about is the contralateral C7. This is a procedure that I had the possibility to observe during my fellowship in China in the department directed by Professor Gu Yudong, and that I introduced in Italy after I went back to my country. I have to say I have treated quite a few patients, but there are a few issues that we have to consider. And right now, my opinion is that contralateral C7 should be abandoned. The main thing is not there are questions about whether it's a safe procedure, if it's providing satisfactory outcome. But the main thing is that it's been demonstrated that the percentage of patients that are able to autonomize the function in the recipient limb are very few. This usually takes a very long time, at least 5 years. And the percentage of patients that are able to autonomize the movement is actually very, very small. There are excellent papers written by my friend and Lukas' friend, Mariano Sokolski, about the reason why, and it's a lack of cortical reorganization and connections. So this technique, for sure, right now, I don't think has much place. So we talked about the last chapter of neurotizations, which are distal neurotizations, techniques which have been introduced by Christopher at the end of the 80s, beginning of the 90s. And the genial intuition of Christopher Berlin definitely revolutioned brachial plexus surgery. I call it the Copernican revolution in brachial plexus surgery. And I think every brachial plexus surgeon with experience knows that we can talk about a before Christopher Berlin's technique and after Oberlin's technique period. So this kind of technique basically is related to using an healthy nerve and selecting from an healthy nerve a donor fascicle to restore the lost function of the recipient nerve. Christophe Oberlein's intuition has opened a new era in brachial plexus surgery. There have been other surgical techniques which have been designed following his example. You are all familiar with Somsack approach for the renervation of the deltoid, and an approach which is a transfer that is less known is Zulmar-Accioli's nerve transfer, which is a transfer of the brachialis branch from the musculocutaneous for the finger flexors of the median nerve. That can be successfully used in lower brachial plexus injuries. So after this overview of the surgical techniques that we can use, I'm going to show you some of the results based on the different injury patterns. So upper plexus palsy, C5, C6, and C7. In these patients, we aim to renervate the shoulder and the elbow. This is a scheme of the surgical strategy that might be applied. Usually, this is what most surgeons use. We use a different technique, which is actually a variant of Oberlein's technique that we designed together with my colleague Stefano Ferraresi when I was working in Italy. That is basically consisting of selecting. So what we do is that we perform the procedure at the infraclavicular level. We use the stimulator to identify fascicles related to the wrist flexion. We select those fascicles, we cut those fascicles, and we co-opt them with the musculocutaneous nerve. So again, as I said, this is something that we do at infraclavicular level, and we have been very happy with this kind of results. It provides excellent results, excellent outcome, and also rules out the need for the double transfer that has been designed by Oberlein later on, and also by Susan McKinnon. This infraclavicular procedure for nerve transfer is something that we have also used with success in patients that presented a different situation than a complete flail arm. There are some patients that present a flail arm, but then after, and they might have avulsions, but one of the roots of the lower roots might still present continuity with the spinal cord. So these patients may regain some function in the finger flexors. So in those cases, finger and wrist flexors. So in those cases, we also apply this kind of procedure with good results. These patients I just mentioned have to be differentiated by the pure upper brachial plexus, because of course they also sustained a damage on the lower roots that eventually partially recovered. So it's a completely different injury pattern. Now, I wanted to show you, this is a C5. So this is a C5, C6, and C7 brachial plexus injuries, which has been treated with the techniques that we mentioned before. And I like to show this video because you can see that the patient presents a twinging scapula. This was a patient we did many years ago. And now something that I would do in these patients also would be, as I mentioned before, to attempt a renervation of the intercostal nerves on the long thoracic nerve to better stabilize the shoulder blade. Anyway, C5, C6 definitely present a very, very good outcome after this procedure. You see, for instance, this patient, he presented C5, C6 avulsions, And after the surgical repair, as you can see, he has regained excellent shoulder function, abduction, and extra rotation. If you have a C5 and C6 and C7 injury, you may repair C5 and C6 the way I mentioned before. And then what we do is we will complete the procedure with the Merle beam transfer. There is a palliative procedure to restore the wrist and finger dorsiflexion. And you can see the result in this video here. So talking about the lower plexus palsy affecting the lower roots, I already mentioned before the Zulmar-Acholi transfer. This is also definitely, sorry for my voice in the video. Okay, so this was a lady that sustained C8 and T1 avulsion, brachial plexus injury after a car accident, and she was submitted to oops, sorry. Sorry. Okay, so as you can see, she has been able to regain a good grip that enables her even to apply nail polish. That is for sure a very precise function. So this is an air transfer I always use with very good results. And then we eventually talk about total plexus palsies. These are the real challenge for the brachial plexus surgeon because you have a flail arm and you have to try to regain the function of the arm. Now, unfortunately, so these are patients that present a very complex and demanding injuries, but we have to consider that from the point of view of the surgical explorations, they are not all the same. So I already mentioned about patients that present initially a flail arm and then they will eventually present a partial recovery of the end function, and the fact that we would treat these patients with a strategy which is similar to the one that we use for the upper brachial plexus. In complete palsies, if we have one root stump, we will try to target the biceps. So here you have a patient that presented avulsions of all the roots with the exception of C5 and was treated with the renervation of the spinati and the biceps. And you see that he has regained quite a good shoulder function and elbow function. This is a more complex case because this young man presented a panavulsive injury. So the treatment that was provided is the one that I mentioned before, the 4 intercostal nerves. Sorry, 4 intercostal nerves. Okay, so here you can see he has regained a good shoulder function. Look also, have a look also at the profile of the shoulder. The trophism, the muscle trophism is quite good, and he's able to lift with this elbow flexion about, this was a bag that was about 6 gauges. And this is another example of a patient with C5 routing continuity, just to show you the difference of what a C5 routing continuity can do. And this is a patient. So this is the, as you can...
Prova a prendere fare vedere che tiri su. Ok. Perfetto, e adesso ci concentriamo sulla mano. Ok, blocca il polso e vediamo sulle dita. Ok.
Okay, so this patient was treated with contralateral C7, as you can see. So there are some remarks I have to do. So you notice that here in the slide I wrote that he also was submitted to an intercostal nerve to transfer for the triceps. But in the video, you see that he has no triceps. This is because the video was done when he still hadn't recovered the triceps. The procedure of the intercostal nerve to the triceps was done in a second stage, and the result was evident later on. And then there is something else I wanted to say about the recovery of the hand. So Nicola, this patient, did recover some hand function, but it was not independent from movement on the contralateral, on the donor side, and it was actually a rather primitive hand function that could not be actively used. Nevertheless, this is the follow-up at 5 years. So you can see that,
okay,
I mean, remember.
Adesso tiralo e ripostalo giù. Ok, adesso fammi vedere con l'altro oggetto. Perfetto. Bene. Adesso proviamo a tirare sulla sedia. Ok.
So he was 50-year-old when he sustained the injury. This is a follow-up at 5 years. He had a complete flail arm, and as you can see, he has recovered a quite good function of the denervated upper limb that provides some dexterity, some bimanual function. So I don't think, so even if in a very complex, very extensive damage of the brachial plexus, sometimes, as I showed in the videos before, our procedures are probably more like salvage-like type surgery. Yet we have to consider that I don't think there is a role anymore for therapeutic nihilism, especially in partial pulses. The results are definitely very good. We also have good results for the infraclavicular plexus palsy. For instance, this was a man that underwent.
Benissimo, bravissimo, piedi. Bravo. Metta giù. Pieghi adesso e sollevi. Benissimo, hai tutto su, dai. Oh, che bravo.
So this was a patient that had sustained a damage on the lateral and the posterior cord. The results on the distal part of the extensor was not very good, and he was, as you could see, in the OT because he was waiting for the procedure of the palliative muscle transfer. These are some clues about what are my main things related to my experience. At the beginning, when I was younger, if I had one root stump, I would try to renervate more targets. Now I try to go for less but safer results. I know that if you have grafts that are longer, 12 centimeters, you are not going to have a favorable outcome. Whenever I can, I use nerve transfer, also because they give me the possibility to provide renervations later than with the graft repair. And there's something that we have to consider. Surgical outcome is not the same based on the injury pattern. The severity of the injury affects the outcome. So you can apply the same result, the same technique, but not get the same results. And this is again related to cortical reorganization and the extent of the denervation. So I give you just one final example. Consider that for the suprascapular denervation, spinal accessory to suprascapular nerve transfer is providing good results for valid extra rotation in 30% of patients with upper brachial plexus injuries, but this percentage decreases in complete injuries that present just one root in continuity with the spinal cord, and no patients with a flail arm will regain extra rotation because there is the denervation of the other muscles, obviously. So I have concluded my second presentation. I thank you again for your attention, and I am available for whatever questions you want to ask.
Thank you so much, Dr. Debora. As usual, a very remarkable and great presentation. Thank you. Thank you so much. Now, for the first opportunity, I think I would like to invite all the panelists, especially my teachers, Dr. Akhmad, Imron, Dr. Ruli, Prof. Tjokorda, Dr. Alfred, Sutrisno, if they have something to say, any comment or questions to Dr. Debora.
Can I ask to Professor Debora?
Please, Dr. Alfred. Thank you, Dr. Alfred.
Professor Debora, thank you very much for your nice presentation. I want to ask you about how many intercostal nerve as you can take for nerve graft or free graft in one moment operation.
So what do you mean nerve graft? We are not using intercostal nerves for nerve graft. We are using them for nerve transfer.
Yeah, how many you can take intercostal nerve for one?
I said I would usually take 4. I would usually take 4.
Which part? Which part?
Yes.
Which part?
Because as I mentioned in the presentation, I would take the 3rd, the 4th, the 5th, and the 6th. So the 3rd is connected to the long thoracic nerve in order to restore the function of the serratus anterior. The 4th, the 5th, and the 6th are going to be used for the musculocutaneous nerve. The motor components, the sensory components of the intercostal nerves, I put them on the I coapt them on the lateral root of the median nerve in order to regain also protective sensitivity in the end.
Okay. The second question, when you use intercostal nerve or you use C2, SSC7 or sural nerve for donor graft?
So if you use the intercostal nerves, you do not use the sural nerve because the idea is that you have to go for a direct connection between the intercostal nerves and the musculocutaneous. Because if you interpose a graft, then this jeopardizes the favorable outcome. So intercostal nerves usually provide favorable results in about between 60 to 70% of cases, but the percentage is going to be affected remarkably if you put a graft in between. So this is the reason why, as I said, we only use till the 6th intercostal nerve. Because if you go lower, then the distance between the intercostal nerve and the recipient becomes longer, and then you need to put a graft, and this is not good for the results. Okay?
Okay, thank you.
When it comes to contralateral C7, as I said, I do not recommend contralateral C7 anymore. For me, it's a procedure that should not have a role anymore, because we have seen that the patient cannot autonomize the movements. In other words, if I can show you, the point is that the patient to activate, so just imagine that this is the brachial plexus injury side, and this is the donor side of the contralateral, okay, C7. So what happens is that the patient, in order to get a movement on the affected side, has to contract on the healthy side, okay? So there is no independency between the two limbs. And what happens is that sometimes if they want to use just the donor side, for instance, if they extend, then they will also have an involuntary contraction on the upper limb, which has been reinnervated with the contralateral C7. And this is actually very bothering for the patient, okay? So contralateral C7 does not provide good results, not because we don't get a good reinnervation of the muscles, but because functionally speaking, the patient is not able to use the reinnervated limb independently from the other side. So it's very difficult to coordinate the use of the limbs. I do hope I made myself clear this time.
Thank you. Thank you very much.
Okay.
Wait, answer.
Cool. Thank you, Dr. Debora. Thank you, Dr. Alfred. Probably.
Dr. Sevline?
Yes, please, Dr. Ahmad Imron.
Yeah. Thank you very much, Dr. Debora, for your very interesting presentation. In my hospital, we have not so many case patient with brachial plexus injury. I don't know why, but maybe because many neurosurgeons commonly in Indonesia already very busy with another case like trauma case, vascular case, or another case. So brachial plexus injury maybe come to another doctor, for example, to orthopedic surgeon maybe. But I hope with Dr. Sevline, she will do surgery for peripheral nerve cases. I hope. I have one question for Dr. Debora. Do you do secondary procedure for brachial plexus injury, Dr. Debora?
Yes, I do. I think I showed in the videos that if I have a C5 and C6, C7 brachial plexus injury, I will try to restore with nerve surgery the shoulder and the elbow function. But then, of course, I have a problem on the wrist and finger extension, and I do that with palliative procedures. Yeah, I do that. I mean, I'm not an orthopedic surgeon, but nevertheless, in my practice, I've learned to do some tendon transfers. Like, for instance, to give you another example, I also perform tibialis posterior tendon transfer for foot drop. So I don't have a complete spectrum of tendon transfers, but I do some that are mostly used.
The second
But
question.
the thing I would like to emphasize is that I understand that as neurosurgeons, there is some reluctancy in considering to learn how to perform tendon transfers. But if you don't want to do the procedure yourself, which is absolutely, something that we can accept, of course, you have to know at least the theoretical background. You have to know the indications for tendon transfers, because if you want to become a brachial plexus surgeon, when you decide the surgical strategy that you are going to apply on these patients, you always have to consider the possibility of palliative procedures to improve your results. So maybe you are not going to be the one that performs the procedure, but you have to know about this possibility. You have to consider that in your in your possibility in your possibilities, and you have to already include that in your repair strategy.
Thank you. The second question is about success rate for nerve transfer. Which one most higher? And I mean axillary nerve. Spinal accessory nerve in internal intercostal nerve or contralateral C7 nerve. Which one more higher success rate, Dr. Debora?
Okay, so first of all, as I tried to show during my presentation, it's not that we consider that all these nerve transfers are on the same level, because we use them for different targets. The spinal accessory nerve is used to renervate the spinati. It usually provides very good results. I would say that you have 90% of satisfactory results on shoulder abduction, whereas the results of a very good extra-rotation are less remarkable. So usually, and this is not only in my hands, if you check on the international medical literature, you are going to see that all the authors, even for instance, Jaime Bertelli from Brazil, have reported that if you analyze the function of the spinati muscles after spinal accessory nerve transfer, you have this difference between the results for the shoulder abduction, as I said, 85–90% or maybe even more, and extra rotation. Extra rotation is not as good as we would expect. When it comes to results from the intercostal nerves, right now we would say that intercostal nerves can provide favorable results in up to 70% of cases. When it comes to contralateral C7, again, as I said, contralateral C7 can give renervation of the muscles, but the point is that the patient is then not really able to use that renervation because of the problems related to cortical reorganization. So we cannot really exactly compare the different kind of transfers because they focus on different targets and they are used in different situations.
Okay, thank you very much, Dr. Debora.
My pleasure, Dr. Akhmad.
Thank you so much, Dr. Debora. Probably another panelist, Dr. Ruli, Dr. Sandeep, or Professor Rasulic. Do you have anything to share or to comment for Dr. Debora presentation? And probably
so I must say that Debora, you did a great job.
Thank you.
Debora, your presentation was excellent, and to I really enjoyed it.
Thank you so much.
I
It's my
practically
honor
use
to
the
have
same
your
strategies. I
appreciation.
also don't do contralateral.
Halo ya Bang?
Okay.
So,
Iya bisa emang udah
oh,
selevel
can you hear me?
Okay. Probably this is a very basic and philosophy questions from the developing country to perform the BPI surgery. One of our students asked, how about the learning curve? Where to start?
Nanti saya masuk
Probably
lagi.
Professor Rasulic, if you want to answer, or Dr.
Yes.
Garozzo.
Well, first of all, I would like to congratulate once again to this also transmitting this webinar through Neurosurgical TV by John Bennett, and this is a nice opportunity for all people to take basic information about brachial plexus surgery and about peripheral neurosurgery. Importance of the learning curve is out of discussion, and this is difficult to systemize, to make it let's say, unify within the different countries, even if they are not low or income countries. But generally speaking, who like to deal with these problems, he can find a way, and the mandatory issue is to work with this patient hard, and then you will try to find the best possible solution. Of course, some mentorship is of outstanding importance, and it's not easy to collect all this data, this information, and training should be at least training under mentorship should be at least 2 years, in my opinion. With let's say high volume center, with high number of cases, speaking only about peripheral nerve brachial plexus cases, and then when you come back in your hometown, your home country, to start to find a way how to take care about this patient. The WFS Committee for Peripheral Nerve Surgery offers a lot of opportunities from colleagues all over the world in terms of accepting them for any kind of training. But this is very hard to achieve in terms of staying in different places over the world for some training. But this also can be organized to organize some particular staying in the low middle income countries and to take care about these patients, to show the people who would like to take into the interest for these patients. And then all those opportunities are on the table, are ongoing. So this is something that I cannot give a more concrete answer about this. Debora, maybe you can say something additionally, but this is something that how we all we have. I would say that Debora and myself were lucky to start this activity in this field in centers which were still are high volume centers, and then that's how we developed our practice. But anyhow, learning curve is steep and long lasting. Even still today, even I sometimes learn from cases, from the patients, from the other colleagues, because this is a very developing and demanding field. Say something about this issue of the learning curve in peripheral nerve surgery.
Okay, so for learning to operate on brachial plexus injuries, first of all, I would say that, as usual, we have to consider that everything has to go step by step. So you cannot just have somebody attempting brachial plexus surgery straight away. this is something that you reach as a final stage after you have a lot of nerve injuries, which may be much simpler and therefore more feasible to be treated. So I think if you have an interest in peripheral nerve surgery, you can start treating single injuries, and then little by little, you are supposed to progressively build up a knowledge eventually enables you to be able to deal with the management of such complex cases like a brachial plexus. I do agree with Lukas on the fact that we certainly, the ones that are now, I'm sorry to say that old enough to have piled up enough cases to have experience and be able to teach should certainly support the young surgeons that want to learn this surgery that is fascinating, because as you could see, it's an intellectual challenge that has no equal in the other procedures of neurosurgery. But the point is that sometimes it's not so easy to find the cases. Like, for instance, when I was in Italy, I had a lot of cases. Because in Italy, we use a lot of motorcycles, and we had a lot of cases. For instance, since I relocated here in the Middle East, in Dubai, there are not so many cases. So I think one of the things that might be organized, and this is something that we had already discussed with Dr. Sevline or also other colleagues, in countries where they really have a remarkable number of brachial plexus injuries, is that probably the easiest thing could be also to train an higher number of surgeons, that one of us, all the surgeons with experience, probably decide to take some time and, for instance, go and spend some days in Indonesia or where else you want to learn this kind of techniques, and assess the patients with them and train them. So that would be, I mean, instead of having also the cost, it's obviously, I'm a very pragmatic woman. So the cost of having just one young surgeon, for instance, from Indonesia coming to Serbia or coming to Dubai or where else would they want to go to learn this surgery with an expert and staying for months, considering that we do not do this surgery every day, would be probably too high. So probably a better solution would be to organize, somebody in the locations where they want to learn, collecting the patients and having one of us going there, and we could focus specifically on brachial plexus injuries. I mean, these 2 lectures that I gave, I tried to squeeze a lot of information in 1 hour. But I mean, if I were, and this was the original idea that we discussed with Dr. Sevline, for instance, I was supposed to stay there for a few days, then we would have started from scratch. I would have considered to, speak about the anatomy and each technique in detail and so on, and teach them how to do them. So I think, yes, having somebody to come and stay with us, it's a good opportunity, but I think it would be much more favorable to do the opposite thing. For us to go there, stay with them, share our knowledge, maybe with 15 students, even 5 or even 2 people that are motivated to learn this surgery.
Thank you, Dr. Debora. I wish we can do the cadaver workshop soon. Really.
Finger crossed. I've been vaccinated, so I'm available to travel now, if they let me.
Please, Professor Rasulic, you want to say something?
No, just to finish this field of surgery will still remain out of high impact of the robotics and other artificial procedures. Although this is a working force to involve these kind of activities in the field of peripheral nerve surgery. But still, this field of surgery will remain in hands of the surgeon. You understand me? So, hand of the surgeon, like here, like in Greece, like which means hand is will be the most important impact factor.
Sorry, Dr. Lukas.
Yes.
Sorry, the voice is very, very not obvious because the microphone, please.
Okay, sorry. Once again, can you hear me now? Can you hear me now? Yes. Okay.
Okay.
So, yes, because I'm now speaking from my phone. Still in 21st century, hand of the surgeon or hair, in Greece, like surgery. Surgery is word surgery is based on a Greek word hand. Will still remain as the most important impact factor in this field of surgery, despite the great influence of the artificial intelligence and robotics, which are already included in all other different fields of the surgery. Here, as you heard from the excellent presentation of Debora's excellent presentation, this will be highest impact factor to treat this patient with surgeon's hand and experience. I don't know until when, but in my opinion, robotic surgery in this field might come in 22nd century.
Dr. Lukas.
Yes.
I see. You are a military neurosurgeon. I have so many gunshot of brachial access arteria. You know, I have now an Idlib.
Yes.
I before I work, but I have 3 cases. I prepare to do it.
Yes.
Any advice for me for gunshot? There's a burning, you know, gunshot multi-level of brachial plexus. Not accident, the gunshot. You know that, or sequestration matter. Thank you.
Individual case evaluation, one by one. I mean, because each case in gunshot injuries can request a different surgical strategy, and always total exposure of the brachial plexus in the field of the gunshot wound. And depending on the intraoperative finding, you can perform either a grafting procedure. This will be in majority of cases, or even if there are some situation for, let's say, long nerve grafts or extensive nerve injury, then you can perform nerve transfers. So this is based on very careful preoperative evaluation.
Dr. Lukas, I prepare every case is this is test examination. I know that, but I tell maybe transfer intercostal like this because we haven't any technology here or only AMG. You know that. Clinically, symptoms and signs here, and there's gunshot. Okay, I see from your opinion.
Listen.
Emergency
in wartime in former Yugoslavia from 1991 to 1995, and even before and even later after, there were no I don't know, MRI, ultrasounds, additional issues. We operated a lot of patients even only based on clinical findings. When we have any additional EMG, perfect. But when you have a gunshot injury, when you have 3 months after the injury that without any kind of spontaneous recovery, you have associated injuries, etc., clear picture that this is you will not achieve. I mean, patient will not achieve spontaneous recovery. You have to explore the patient and to find a solution for this. And at that time, we based this on interoperative findings. We decide what kind of treatment strategy will based on interoperative findings. Nowadays, we can carefully prepare the patients on the basis of preoperative evaluation, correlation of the clinical examination, and additional diagnostic procedures such as MRI, ultrasound, EMG, etc., But still, this remains the same in gunshot injuries. You understand me?
Okay. Thank you. Again, Dr. Lukas.
Dr. Homer.
Okay.
Dr. Homer, may I say something?
Okay. I'm with you.
I understand. Okay, so I understand you seem to be under pressure because you have a lot of patients, and probably you have very much help to do those cases. Okay, so also considering that Syria and
Yes, north of Syria, Idlib.
far away,
We
so
are
we
like a
more or
prison
less
here.
also share the time.
Dr. Debora. We are here at
Okay,
Idlib.
so
This, I like a prison here at Idlib, Syria, of north of Syria. You know that. That government here.
yeah, I know. But no, but what I'm telling you is that because we also don't have the problem of being far away from each other, so the time is more or less the same. We don't, like, for instance, if I were living in America, it would be more complicated to interact, the two of us. I will give you my, maybe Dr. Sevline, can you, because I think you probably have my email and contact number. You could kindly, don't mind, provide that to Dr. Omar. Dr. Omar, we can directly start to interact. And if you have cases, I can give you all the background, theoretical background that you need. And maybe I can also help you to deal each case. Okay?
Thank you very much, Dr. Debora.
Dr. Omar, we will send Dr. Debora contact to your email. Yes.
Okay.
Yes.
Sure.
And of course, everybody who needs help, I'm available. Just 1 second, sorry.
Yes, sure. So.
Hello, everybody. Yes. I just want to congratulate once again. I would like to excuse myself because I have some other obligations. The webinar was excellent, and I hope it will stay on the YouTube, on the network, so people can watch this webinar even later. Not live, only live like now, but later on because this is a great presentation, great organization, great discussion, and I thank you very much for this kind of invitation. So I have to leave now, and I hope to see you soon, and I'm on disposal for everything what we discussed. Okay.
Allah bless you. Allah bless you. With you.
Yeah, thank you. Thank you.
Allah with you.
Thank
you.
Bye, Lukas.
Bye.
Goodbye. Allah bless you.
So I think we have Dr. Ruli, you haven't said something. As panelists, you want to say something, please?
Yeah, actually, I'm not a peripheral nerve surgeon, so I don't have any question about. I do interest about why in Indonesia the peripheral nerve cases is very low. I don't know how to increase it because maybe it's because the culture, or it's just under the iceberg phenomenon. I don't know. But I saw here is Dr. Ferry Senjaya. Ferry Senjaya is one of the pioneer of the peripheral nerve surgery in Indonesia. Maybe Dr. Ferry, if you watching and hear me, Dr. Ferry Senjaya.
Yes, Dr. Ruli.
Yeah. Dr. Ferry is one of the first pioneer peripheral nerve surgery.
No, not really. I'm still learning. I'm still learning.
Yeah, you always are learning. Maybe because all the peripheral nerve expert here, maybe you can share why we have so very limited case in Indonesia.
I can tell you why.
Why?
Because traffic doesn't move in Indonesia.
Very nice one there.
Traffic is better now. Traffic is better.
Is it better, really?
It's better. It's no move at all.
These are mostly high-speed bike accidents. If you are going slowly, then actually you won't have these injuries.
But it's not move at all now. Very traffic.
No injuries.
Okay, please, Dr. Ferry, do you have something to share to us?
Well, from what I'm seeing, I think, in my own experience, we don't have a lot of cases, even during my training as a neurosurgeon back in Bandung in Pajajaran University. I don't think it's not because we don't have the case, but I think it's because it's underdiagnosed, I think.
Yes.
Lots of our, maybe we don't have a lot of experience in properly examining the patient to know whether there's a concurrent injury, for example, a patient with multiple injuries involving head injuries. Sometimes you don't examine the patients enough to detect possible nerve injuries as well. And us as a neurosurgeon in Indonesia, like Dr. Imron also said, that we are too busy dealing with brain and spine surgery, and we're not putting enough attention in peripheral nerve surgery. And I think all other specialties around us that's also dealing with trauma patient, they haven't seen us as a specialty that is handling this case. So probably most of the cases are either referred to orthopedic surgeon or maybe underdiagnosed.
I tell something.
Okay.
Dr.
Okay,
Debora.
Oh yeah,
Dr.
please,
Debora.
please, Dr. Umar to Dr. Debora.
Brachial Plexus. This will attend to any new neurosurgeon when he study neurosurgeon. Depend on his what he like or he study. If he like brachial plexus and study well, he like brachial plexus and its surgery, because surgery is anatomy, you know, and physiology. If not like and only examine and he is specialist, not his mind on brachial surgery. I see that. What do you do, opinion, Dr. Debora?
Okay, so my opinion is actually that, okay, so my opinion is actually that peripheral nerve generally speaking, has been definitely neglected by neurosurgeons. We don't even have a proper training for the residents related to peripheral nerve surgery. So there is not an interest. There is a complete neglect, and I'm not just talking about the nerve injuries. I'm also talking, for instance, about entrapment neuropathies. A lot of entrapment neuropathies sometimes go underdiagnosed or are overdiagnosed exactly because we do not have a great knowledge of this part of the pathology. Have let other subspecialties, like for instance, plastic surgery, orthopedic surgery, to be the ones mainly dealing with this kind of procedures. And this is a huge mistake because at the end of the day, we should not forget that nerve injuries means that we are dealing with the peripheral nerve system, which of course is part of the nervous system on a larger extent. And I don't know if you noticed that, but during my talks, I mentioned quite a few times cortical reorganizations. And this is something that, for instance, an orthopedic surgeon or a plastic surgeon will never do because they have no idea of what is cortical reorganization or plasticity. So I think it's time that the neurosurgeons are trying to understand that this actually should be a subspecialty in the hands of the neurosurgeons. As I said, we might need interdisciplinary collaboration when it comes to tendon transfer or whatever, but I think we should focus on that. I mean, after all, neurosurgeons are mostly do spine surgery, which is something that is perfectly done by orthopedic surgeons. We had orthopedic surgeons dealing with their herniated lumbar disc much earlier started to deal with them, okay? So it's just related to the mindset, I think. And I agree with Dr. Ferry when he said that probably a lot of injuries are not even recognized or they simply do not get to access treatment.
But not tell me, Dr. Debora, about yourself. Why you choose the brachial plexus surgery? You choose neurospecialist. First time, first step.
No, it didn't happen because I chose. But it happened just because.
There's chance, or you like this plexus. for this new surgeon to how to choose his specialist, how to determine about as he's studying and doing plexus surgery and spine and neck and posterior fossa, middle fossa, aneurysm like this. You must to know all like GB, general practitioner.
Okay, so this is why I'm saying that we need to introduce the study of peripheral nerve surgery for the residents, and we have to provide a thorough information about this pathology, because if we don't do that, we always have young surgeons that finish their residency and have no clues about peripheral nerve surgery. So education is of paramount importance. Personally, I'm trying to do as much as I can. I mean, I'm always available to do webinars. I was doing a lot of hands-on courses before COVID and everything. So from my side, I am absolutely available to help anybody that wants to start dealing with this kind of subspecialty. But of course, we also need something different. The societies, the neurosurgical societies are the first ones that should be taking the role of highlighting the importance of brachial plexus surgery or peripheral nerve surgery, generally speaking.
Dr. Debora, one note, please, for all neurosurgeon, when he comes to neurosurgeon to the specialist, you must to know like GB, like cardiologist, endocrinologist, and cardiologist, like surgery, brain surgery, calam surgery, and peripheral surgery, nerve surgery. You must to know everything. The examination must to do to make at least 30% of information about this kind of knowledge. Every neurosurgeon you must know, and he choose after that the specialist what he mind to do after that. I think that. Thank you.
Thank you, Dr. Omar.
Thank you.
I think, is there anyone from the panelists or Dr. Farid Sanjaya want to give additional comment, or Dr. Debora? No?
Yes, there is an interesting question. There are a couple of questions. So one is about artificial biomaterial, and the other one is about repair of brachial plexus followed by transcranial magnetic stimulation. And I would like to give a quick replies to both. Okay, so talking about artificial biomaterial. We have seen that artificial nerve grafts do not work if they are longer than 3 centimeters, okay? So this obviously at present rules out the role for artificial nerve graft, for sure. So this was the first question. And the second question was given by Dr. Jafri Malin about brachial plexus repair followed by transcranial magnetic stimulation. And to be honest, I would like to know more about the follow-up of these patients, because yes, I do believe that this might be a good way to stimulate cortical reorganization. I don't have an experience with that personally, but I think it's a study I definitely would focus on.
Dr. Debora, one question, please. Do we use stem cells in peripheral nerve or visceral nerve surgery?
Never.
Because
never. No. I mean,
I only asking.
Yeah.
We can use in future.
No,
there's because you know at spinal cord surgery, 3 centimeters. Maximum, like nerve, peripheral nerve.
Okay, so I'm sorry, but I have to adamantly at present there is no, Dr. Omar, if you let me speak, there is no role for stem cells in brachial plexus surgery or nerve surgery, generally speaking. And I'm sorry to say that, but if you review the medical literature, you are going to see that the results also for spinal cord injuries are actually definitely less promising that we expected at the beginning. So stem cells have been very well advertised. There has been a lot of speculation about that, but unfortunately we have to admit that they have been a failure. At present, it is like that, and I do not believe that they are anything else than a commercial enterprises. It's not surprised that they are just done in private institutions and no government facility actually provide stem cells treatment.
Thank you very much for you.
Thank you so much, because as the schedule, we have to end this at 4:30 in Indonesia time. So I think if we already finished with all the questions. Yes, please, Dr. Ferry.
May I have a question for Dr. Debora?
Please.
Dr. Debora, what is your usual strategy for patients with neglected brachial plexus injury? Because in Indonesia, many times we see patients coming to the clinic 2 years, even more after the injury. And lots of them are patients presenting with flail arms. So what is your usual strategy for these patients?
Okay, so in patients that came to my observation even 2 years later and they had partial injuries, I always went for surgery anyway, using nerve transfers, and I did some results. Of course, it's occasional, so I don't have like a large series about them, but I can tell you that I treated even a patient with a C5 and C6 injury about 3.5 years after the lesion, and he did present improvement. When it comes to flail arm with abulgions, I think that unfortunately, there's not much to do. And we can probably try to see, for instance, if we can do something with joint arthrodesis or something like that. But I think in that case, the battle is lost. If it's a flail arm with avulsions, it's too late and we cannot do much. So this is why it's important that we identify the patients, we screen the patients as early as possible, and we give them correct indications for treatment in the frame of the proper timing. So this is why we have to create the culture of brachial plexus injuries, because we have to provide information to as many physicians as we can in order to prevent that a patient is left for 3 or 4 years without any treatment.
So would you still try to pursue a primary nerve repair in this kind of patient, or do you have a certain timeline when you consider that there's no place for primary nerve repair, either transfer or graft, and pursue palliative surgery or maybe a gracilis muscle transfer maybe?
As I said, in partial injuries where I can attempt, for instance, a spinal accessory to suprascapular nerve transfer for the spinati and the transfers for the biceps, I have tried them and they worked. Of course, I would say that you need to carefully preoperatively study the patient. So, for instance, I did MRI to show that there was not complete fatty degeneration in the muscles, and we also checked with EMG, and if there was still presence of fibrillation, this can show that there might be some potential for recovery. There were cases of partial lesions, and the ones I'm talking about were mainly upper brachial plexus injuries. When it comes to complete palsies, so nerve grafts have been demonstrated not to be able to provide good results after 1 year. So as I said, the only hope is if you can apply procedure like nerve transfer. But in a flare which is already burdened by so much failure, in panavulsive injuries, even within the proper timing, I certainly wouldn't attempt the procedure. And as you said, yes, we have to go probably for palliative procedures if we can apply them.
Any experience with gracilis muscle transfer, Professor?
Any? Sorry?
Do you have any experience with gracilis muscle transfer?
Not personally, I don't do them, but I have seen a lot of cases treated in China or in Taiwan. And okay, I will tell you my honest opinion. I understand that patients are desperate and they want to regain function as much as they can, and of course on the other side the surgeons want to favor some functional restoration. But I always try to say that we have to distinguish between what I call the surgical denervation or the surgical restoration of function and the real restoration of function. And in reality, I have seen that all the patients that were submitted to these heroic procedures like the gracilis transfer, whatever, at the end of the day, it's not that the patients really regain the use of the upper limb in a way that it can result useful in their daily routine. Because it takes a long time, and it's anyway, especially when it comes to the function for the finger flexion, a very primitive and very mechanical function. So I will give you this final remark. I am a brachial plexus surgeon, okay? And I think I gained quite a lot of experience because I've been doing brachial plexus surgeon for about 20 years or probably even more. If nowadays I would become a patient with a brachial plexus injury, personally, with my knowledge, I wouldn't go for free gracilis muscle transfer. I don't think that the price you pay is worthy the result you get. And my philosophy in surgery has always been that you have to try to get the maximum result, trying to minimize the price the patient has to pay for that, and also not to risk complications. At the end of the day, as I said before, this is a surgery we do to improve the life quality of the patients. We are not supposed to jeopardize their overall well-being in any way. That would be my final remarks.
Thank you so much, Professor.
And then, if I may say something again, as I said, I'm absolutely available to share my experience with any of you. I would kindly request Dr. Sevline, that has been a lovely organizer, and it was really a pleasure to interact with her through all these months. If anybody of you is really interested to touch base with me because you have some cases you want to discuss or you want to help, or whatever, I mean, just feel free to touch base with her, and she can provide my contacts, and I will be absolutely happy to try to help as much as I can. I think Dr. Sevline already had the experience that if there is anything, I'll try to get back to whoever contacts me as soon as I can.
Sure, Dr. Debora. If any participants want to get the contact of Dr. Debora, because we will not spread it sporadically, so I think you can put your email address in the chat column, and we will send the contact of Dr. Debora privately to you by your email. Thank you so much, Dr. Debora Garozzo. It's very remarkable webinar discussion, and I really hope we still can do the cadaver workshop. To all the participants that has registered to the previous cadaver workshop that we postponed on the last April, it is still registered until today, because we will do the cadaver workshop as soon as the pandemic ends.